All ready.
We are live in 5, 4, 3, 2, 1. We are live now, sir.
Hi, good evening, everyone, and very warm welcome. And we are back again with the second series of the MIS. And here we are going to have a great faculties and who will be teaching us a lot over this entire 1.5 hour session. I am Chiranjeev Rampal, the product manager for the Neuro and Spine Division in AOSYS, and it is my pleasure to host this second edition of our webinar series. Okay, now this webinar series we got an overwhelming response in the last one, and we are getting back with some more exciting and more engaging, packed with a valuable learning opportunities. And our objective is simple: to bring the renowned expertise and latest advancement in the spine surgery and create a platform where meaningful academic exchange is happening. And today, for the entire session, we have great faculties who have been joining us. I would like to specially introduce the chairman of this event for the webinar series, and he's none other than Dr. Amit Jhala. Dr. Amit Jhala, sir, has been widely recognized as one of the India foremost pioneer in minimally invasive spine surgeries, and he is an immediate past president of MESA. He has made witness the evolution. He has actually shaped in the Dr. Amit Jhala, sir. Thank you, sir, for joining in.
Thank you very much.
Thank you. So second, our co-chairman is none other than one of the privileged who is a true pioneer in the spine care, Dr. Ashish Tomar, who is a director in orthopedic at Sarvodaya Hospital, Faridabad, and as an orthopedic and minimally invasive spine surgeon. With over 17 years of experience, he has done more than 1,000 spine surgeries, and he has been trained under two legend surgeons, from Japan, that is Professor Kokuban and Dr. K. Abumi. I'm sorry if I have pronounced the name not properly. I'm sorry about that. And he has also distinctively performed or holds a distinction in the of doing an OLIF L5S1 in Faridabad. Not only that, he's a recipient of a Young Jewel Award from the Indian Medical Association and a regular presenter at National and International Spine Forum. Welcome, Dr. Ashish Tomar, for this wonderful session, and you are the fresh face for this webinar series.
Thank you, Chiranjeev. Thank you.
Thank you. Our next faculty is an international faculty who's been known as by Dr. Swarnakumaar. He has been in the leadership point and been a past president in Sri Lanka Orthopedic Association and even a past president of Sri Lanka Hand Society. He is pioneer in introducing of minimal invasive endoscopy spine surgeries in Sri Lanka and has obtained a fine training from Germany. Thank you, sir, for being on today's webinar, and I hope in the last previous session we'll get all your experience and indulge us with more of the case study scenarios, sir. Welcome on board, sir.
Thank you, Sanjeev. Thank you, everyone.
And the next faculty is the youngest among all, and he has been very active not only in the social media but also in terms of his cases as well. He not only posts his minimal invasive spine surgeries but also the deformity. Currently, obviously, he has published 13 peer review papers in leading journals, including the Journal of Minimal Invasive Spine Surgeries and also in the AO Global Journal as well. And currently, he's also working with the new projects and his own software where he's trying to lead the spine surgeons in the OR with the help of the software. I think so. He will speak about it more in the coming sessions as well. But I thank you, Dr. Sharvin, sir, and please welcome for the webinar series, sir.
Thank you so much for your kind words.
Next, we will be having the agenda for the session. Will be the series where we will be doing a small introduction. Since I am from the AOSYS, and I will just like to introduce myself completely and my company profile overall. So we are a company based out of Ahmedabad, and we are going. We have been 4 years old now, and currently in spine 3 years old, and we have been growing steadily in India with good qualities and good instrumentations overall. Our vision is to be a leader in the medical technology, innovation, and a special focus on orthopedic spine and trauma products overall. And that is a focus for upcoming for entire decade as well. Okay, and at AOSYS, we basically focus on the quality And since we are a local company around here, we do see the dynamics and we tailor it in terms of the efficiency of the product. And we also believe in doing the training educational activities overall. So not only we are doing the webinars, we are also conducting many other courses like hands-on workshops, webinar series, cadaver or fellowship as well. And for in those instances, we have also brought up a young surgeon clinical exposure and observation program where where we try and introduce the young surgeons who have not very well experienced or who like to take an experience from the renowned surgeons in pan India level basis, and we see what we can do to groom them and overall educate the mass entirely. For the today's session, we are back. We are going to have the second series, and the next topic, or the very first topic, which will be taken by Dr. Sharvin, which will be on the biomechanics of the pedicle screw and interbody cages. Over to you, sir. Thank you for joining in.
Thank you. Thank you. A very good afternoon to all our viewers. I'll quickly share my screen. And is my presentation visible?
Yes, sir.
Okay. So as we all know that today's session is going to be about fusion techniques and minimally invasive spinal instrumentation. So I'm going to be talking about the very basics of instrumentation, which is the biomechanics of pedicle screws and interbody cages. So we all know the vertebral body consists, the vertebra consists of the vertebral body, the pedicle, an end plate, a disc space, and the facet joints. And the biomechanical loading of the spine happens in various moment of forces. So instrumented constructs must resist all 6 degrees of freedom. It is not just a biplanar or a triplanar movement. There is a complex movement occurring at the spinal joints, which the implant has to bear. So understanding each load type also helps in implant selection. So the implant should be able to withstand forces of axial compression and tension, flexion and extension, lateral bending, rotation, as well as shear forces, and not just a single type of force at a time, but a combination of forces when the movement occurs. So a pedicle screw is something that we use routinely in our spine surgery practice, which consists of the polyaxial head, which are the most common types of screws used. All our minimally invasive screws are polyaxial. There is an outer diameter, a thread pitch, which guides the speed at which the screw is inserted inside the body, a core diameter, and a tip which can be self-tapping, and now we also get self-drilling types of screws. So how does that affect the biomechanics? The screw, it allows the multidirectional rod placement because of the polyaxial head. It distributes the cantilever stress. But a monoaxial screw offers higher construct rigidity. A larger outer diameter means the pull-out strength of the screw is also higher. Bending stiffness of the screw is decided by the core diameter, and a larger core resists fatigue fracture due to repeated axial loading. So axial pull-out strength is the force that is required for the screw to be extracted axially by constant forces. And it is directly proportional to the bone mineral density. So especially when we are operating a degenerative spine and an osteoporotic spine, axial pull-out strength plays a major role to prevent the implant failure. And a larger outer diameter and a longer engagement increases the pull-out strength, which means that you will need more forces on the screw for the implant to fail. And cortical pedicle wall purchase is critical, and not just the cancellous core, because the pedicle is where the maximum hold of the pedicle screw is. Bending loads are because of the cyclic flexion extension, and it creates toggling at the interface. This happens because of flexion extension moment of the spine. And if the bone quality or the screw purchase is not strong, it can lead to loosening of the screw and therefore failure of the construct. Longer rods also increase the lever arm. Therefore, it gives a high amount of forces on the screw. So which is why we see junctional problems and implant-related problems in longer constructs as compared to a single level construct. And insertional torque is the intraoperative proxy for purchase quality of the screw. It is highly reduced in osteoporosis. Cement augmentation is therefore used by many of us for strengthening the implant construct. So how is the pedicle screw fixation? How does the strength of the pedicle screw fixation affect our practice? So bone mineral density is the single most important predictor of the pull-out strength, and osteoporosis usually mandates augmentation strategies in the form of rigorous osteoporosis management by teriparatide or monoclonal denosumab. We can also add cement augmented screw fixations, which will therefore increase the pull-out strength. The larger outer diameter, as discussed previously, is also preferable. Longer the screw, it engages more bone, and therefore it gives a better construct of the screw. Fluoroscopic navigator robotic screw. So what technique we use for screw insertion also plays a role, because navigation guided and robotic screw placement gives a maximum uh, lateral to medial trajectory or conversions of the screw, which therefore helps to maintain the construct strength. Segment augmentation, rescue larger screws, or uh, lengthening the strength of the construct in the form of iliac screws or S2AI screws. These are the salvage strategies that we use for implant failures. And most of our screws are titanium, which are MRE compatible. Now the pedicle screws are available, which also have a cobalt chromium head and a cobalt chromium rod system, which is very stiff, and the fatigue failure is also very high. So pedicle screw and rod construct mechanism also varies according to the material. The load distribution, the rod stiffness, fusion levels, and what type of screw we are using determine the strength of the construct. We also sometimes additionally put crosslinks in multi-level constructs to add the torsional and lateral bending rigidity for it. Usually, a crosslink is used for longer constructs such as the adult degenerative deformities. Interbody cage is something which we use routinely for a fusion because not just for better anterior column strength, but it also provides a better disc height restoration, a good strong anterior column support, and adds to the segmental lordosis. And there are multiple approaches by which we can insert the interbody device into the disc space. It can be an anterior, it can be a retroperitoneal or the O-lift approach, it can be a direct lateral approach, the transforaminal approach or the T-lift, which is most commonly used, and P-lift, which was used once upon a time. And the choice of approach is usually driven by, most importantly, the indication of the patient's symptoms and pathology, and then the amount of lordosis required, and of course, the surgeon experience and skill also plays a role. So anterior column load sharing is important because anterior column bears 60 to 80% of the axial compressive load, and it therefore reduces the stress on the posterior screw rod construct. So if we do not put an anterior interbody cage, all the load is on the posterior construct, and therefore it can lead to an implant failure. The peripheral rim of the end plate is the strongest and a large more stronger construct. If the cage is small and if it is not residing on the cortical footprint, there is also a chance of subsidence because the cancellous bone is weaker than the outer apophyseal ring. So a few interbody cage design parameters. So footprint of the cage is nothing but the cross-sectional area of the cage. And as we all know, the A-lift gives the largest cages, but it is technically demanding. You need specific retractor systems, a specific set of skill. But now we can also put O-lift or L-lift cages through the T-lift approach. And that gives a good cage footprint along with a very strong mechanical construct. The lordotic angle also plays an important role in the construct because even single level fusions, if not restored properly, and if we create an iatrogenic flat bag, it can lead to global, regional and global spinal imbalance. Right. We also have the technology of 3D printed cages, which allow better osteo integration of the cage because of a good bone ingrowth and therefore early fusion. Cage height restores the disc height and leads to a jacking up effect which also decompresses the foramen. Many materials are used for the cage, like PEEK, which is common, titanium, which is also commonly used, which now has 3D printed designs, and also nano titanium surfaces, which are also produced by a few companies. So a 360 construct gives a synergistic biomechanics. Pedicle screws restore the posterior tension band, and anterior column is supported by the interbody cage, which gives a better superior stability versus any of it alone. So hardware failure is something which we commonly see in our practice. And it can be a screw fracture, it can be a pseudoarthrosis, it can be a cage back out, loosening, breakage of the screw, breakage of the rod. It can be any of this complication, which is either a hardware failure or a biological or a fusion failure, as all our fusions are usually a race between the failure and fusion. So pseudoarthrosis, there is a 5 to 15% risk incidence, and there are the common known risk factors. Cage subsidence can occur if there is an end plate violation during the end plate preparation part of surgery. If there's an infection or biofilm, which is seen in PEEK cages, and adjacent segment disease, which occurs in longer constructs if the spinopelvic alignment is not restored adequately. And of course, there can be neurological and vascular anomalies, which can happen, injuries, which can happen due to screw malposition or cage migration or during any of the implantation techniques. Adjacent segment disease and long-term biomechanics of the spine also play a role, and therefore sagittal alignment is the single most important factor to prevent an adjacent segment disease. So we all know the PILL mismatch criteria and how we should be adequately restoring the alignment and segmental lordosis to give better long-term clinical and patient-related outcome measures. And now we also have expandable cage technology, which help in such lordosis restoration. They can be placed through navigation or robotic guidance. BMPs are also commonly used in many parts of the world for enhanced fusion rates. And we also have the cortical bone trajectory which gives a higher pull-out strength in osteoporotic patients. So the key takeaways are a pedicle screw fixation strength is primarily determined by BMD, and it might require augmentation strategies. Interbody cages are extremely important when we are planning a fusion of the spinal segment. PEEK is a preferred implant because it reduces stress shielding, but 3D printed cages offer superior osteo integration, and therefore they are getting popular very fast. And combined 360 fusion delivers the highest biomechanical stability and fusion rates. Sagittal alignment restoration is equally critical and has to be followed. The rules have to be adhered to prevent to achieve better long-term clinical results. Thank you.
Thank you, Dr. Sharvin sir, for a wonderful slide. I think so. This biomechanics and is a very integral part, I think so. And especially if you're covering the sagittal balance, that is one of the most important concept that we have as of now. And plus the adjacent segment disease, because we usually do the cases, but the adjacent segment usually get affected somehow. That's a great presentation, sir. I think so. We'll take the questions and air at the end of the session because we have already 250 plus viewers, and they are just pitching in some more as well over the Facebook, YouTube, and OrthoTV account. And then we'll take the questions up next. But thank you very much for such an
Sure.
informative.
Thank you.
Thank you. Next topic will be taken by Dr. Swarnakumaar, and it is one of the most important topic in the MIs. It's the MIs pedicle screw insertion. We have been mostly doing open cases, and those who have been doing most of the cases, but open cases are, we have been practicing a lot. But for the MIs, how to go through it, I think so. Dr. Swarnakumaar will be able to take through us. Swarna sir, please welcome.
Thank you.
And over to you,
Thank
sir.
you. Yes. Can you see my slides?
Yes, sir. We can see you.
Okay.
Sir.
Thank you. Thank you for everyone for giving me this chance to talk about this minimally invasive pedicle screw technique. So this is my background. I am from Sri Lanka. Surgery, why is it important? It provides a percutaneous stabilization with minimal muscle dissection and reduces blood loss, postoperative pain, and hospital stay. and it's ideal for trauma, degenerative instability, spondylolisthesis, and deformity correction. And it can be a short or long segment fusion. So it reduces the paraspinal muscle injury, because when we go for open surgery, we dissect all these paraspinal muscles to get the entry point to introduce the screws. But here we are only minimally introducing this technique, so less muscle damage. And because of that, there is low infection rate and fast mobilization, because of the muscles are intact and the patient is very comfortably mobilizing. Less post-operative analgesia needed, and smaller incision, it is cosmetically, it is accepted by the patient well. So before going for this instrumental technique, we must know some anatomy relevant to this MIS. Pedicle orientation, we should have a clear idea of how they are located. If we take L1 to S1, it varies from size to the direction. Lumbar pedicles increases mediolateral angulation when it goes down caudally, and when it goes to the S1 pedicle, it is wider, stronger, and it specifically allows bicortical perches to have a better stabilization. So preoperative planning in this instrumentation is important. We should have a CT scan with diameter assessment of each pedicle. That will help us to have a better idea about its screw strength and trajectory. Fluoroscopic or navigation can be considered for planning. And skin incision, it has to be marked based on the pedicle projection on the AP X-ray view. So this is the positioning of this patient. There are special tables for assessment. It has to be a radiolucent table. Abdomen has to be free to reduce venous pressure, so the bleeding will be less. And C-arm has to be moved from top to bottom, allowing each and every angle for introduction of the screw in a better way. If you are using navigation, it is registered first, and then we can use the navigation system for insertion of the screws. So as far as the instruments are concerned, we need a Jamstedi needle that is shown with a green handle, and K-wires, as you all know. Serial dilators are important, because once you put the needle and the K-wire, then we have to pass the serial dilators to widen the muscles and the skin incision. And once we insert the dilators, then we use the cannulator tap, cannulated pedicle screws to go inside the widest diameter of these dilators, and rod insertion and persuader is a different instrument we have to use that percutaneously. So this is one example, skid marking. First, we have to identify the pedicle. For that, we should have a proper AP view of the spine. Spinous process has to be in the center, and both pedicles have to be equally visualized symmetrically. So we have to identify the lateral border of the pedicle, because that is the entry point we are going to enter as we are angulating medially. So our skin incision has to be planned 1 to 2 centimeter lateral to the pedicle shadow. So then we'll be able to angulate medially to get better purchasing of the screws. We have to try our best to ensure symmetry on both sides. This is another diagram. It shows how the pedicle first inserter is inserted, and then guide wire is passed. This is the position to have all these guide wire and inserters. So to get the parallel positioning of the screws to the upper end plate, our entry point has to be at the center, and then we have to aim towards the opposite side transverse process, so it will be going parallel to the upper end plate. That's the important part of this screw fixation. If you don't have a proper planning, if you don't have any idea about this pedicle trajectory, then this will be the end results the screw might go inside the canal and the patient has have a devastating complication in the future. So it can be avoided by having a proper idea of anatomy and proper planning. Well planned is half done, so we have to be very careful. So step 2 is after the skin incision, we use this jumpstick needle. This is a placement at the lateral border of this pedicle, and it is advanced, and we have to be careful that it does not breach the medial wall until we enter the vertebral body. So this is a key point. We have to be careful, and it has to be in the AP and lateral view in the fluoroscope. Aim towards the pedicle center always to have a better purchase and the positioning. So this is the diagram. It shows the positioning of the K wires after putting this needle. Then K wires are passed into the needle, and we have to remove the Gemstone needle carefully without dislodging the wire. We have to be careful. Usually the wire tip is having thread, so once it is inserted, usually it doesn't come out, but we have to be careful with AP and lateral view confirmation, because this is the key part, keeping the wire in the position. Then everything will be easy. Next one, we use the dilators, serial dilators, from small to large diameter, and once we use the dilators, then we have to use a cannulated tap, and then we have to use the screws. Screw insertion, again it goes over the cannulated screws. It goes over the K wire. As our previous presenter mentioned, the diameter of the screw is paramount important. We have to select the proper diameter of the screws. Otherwise, the screws will be holding only in the cancerous screw. It can come out. So usually for lumbar screws, we recommend 6 to 7.5 millimeter, and length is vary from minimum. Usually it is 40. It may go up to 50. And S1 screws, usually we can go to 7 to 8 millimeter screws, and it may be 35 to 45 millimeter screws. Usually S1 screws, we recommend to have a bicortical purchase. Our screw has to aim to the sacral promontory anteriorly, so it will have a bicortical purchase. Screw depth and convergence has to be checked in each position with the X-ray. This is after insertion of these screws, and the sleeves are removed, and we are about to pass the rod. This is ready for passing of the rods. So in some conditions, as our previous speaker said, the osteoporotic bone, it may have the chance of pulling out. So we should have the augmentation screw. After putting the screws, the special screws, they have holes at the tip within the cancerous bone. So there's an instrument or device we pass through the screw head before putting the rod, and then we have to pass cement in the semi-liquid form, and then once it hardens, then we can put the rod. This is the principle of augmentation screw fixation. So then we pass the rod. For that, there's a separate instrument. It aligns with the screw head we have already fixed, so it will align well. So when we are passing the screw, we have to be careful. It goes under the muscles and then align with the screws already we have passed. For the short segment, it's not a problem. When we are using for the long segments, then we have to be very careful. Alignment may be difficult, and it goes subfascially. The rod, it goes subfascially. It engages the screw heads sequentially, and persuader is needed to strengthen the position of the screw rod. Then we go for the final tightening. So we can apply compression or distraction as we needed, whether according to the level of the fusion. confirm construct alignment with the fluoroscope at the end. So this is already, the next talk will be on the cage position. I am not going to talk in detail on this one. And we have to have the proper fluoroscopic landmarks. I am stressing on it. We have to have the equal symmetrical teardrop appearance of the pedicle. In the lateral view, the screw tip within the vertebral body, we have to avoid using longer screws because that doesn't have much of advantage. We can use only about 5 millimeter, 0.5, 5 millimeter shorter screw. That'll be safer than using a longer screws. It can cause complications. And medial breach always have to be considered. This is the difficult part. This is a major complication can happen as I showed in the previous CT scan. So complications can happen due to the pedicle breach, especially medial, and KY migration, neurological injuries when it breaches the medial cortex when the screws or the instrument goes into the canal. Screw malposition, it may end up in weaker stabilization and screw strength. It can end up in pull-out. Infection is rare in MIS surgeries and postoperative care. Because of this MIS fixation, we can mobilize early. Minimal analgesia is needed. Usually they are discharged 24 to 48 hours and follow-up x-rays is taken in 6 weeks, 3 months. And as we said earlier, there's a relay between the screw position and the fusion of this bone mass. So we have to be very careful in mobilizing the patient in this. Just I want to show this case. This is an L1 chance fracture, 40-year-old male. He has normal neurology and we have done the fixation with a minimal incision. He came after 3 months. He is pain-free and well united. And this another one after the endoscopic, after the stabilization is an endoscopic decompression of the disc level. It is done one of my cases. And this another case.
So
Yeah. So
we
we'll stop
have
it.
the session for sharing the cases, I think so.
Thank you.
Yes, if you can just conclude, that will be great, sir.
Okay. Thank you. So I am concluding this with these previous 2 cases. Thank you so much.
Thank you. We will be coming back to you, sir, during the case discussion. I think so. That time we will present it overall. Okay, but it was a great, sir. We saw a couple of what do we say, night dreams images of the pedicle screw going medially completely. And I also have some couple of questions. Maybe at the end of the session, I will be dotting out to you. So thank you very much for giving us the entire nose and house of inserting the pedicle screws. Now, I would like to call upon the next speaker, Dr. Ashish Tomar, sir, who will be taking us to the MIS TLIF surgical workflow. Now, this is the one important aspect because this will be from the start to the end. What knows and hows, what right and wrongs that has to be done during the entire surgery. How to take the X-ray, when to take the X-ray, what does it feels around. Okay, this is the complete complete presentation will be given by Dr. Ashish sir, and he is a very well experienced surgeon. Overall to you, sir.
So am I visible, Chiranjeev?
Yes, sir. You are audible and visible both, sir.
So let us, discuss about how to do this procedure, MIS TLIF, with the surgical flow. So I'm Dr. Ashish Tomar, Director Orthopedics and Minimally Invasive Surgery, presently working with Sarvodaya Hospital. So the benefits have already been discussed by Dr. Swarnakumaar. We can see this is what we used to do when open surgeries were there, and today is in our era of minimally invasive, and most of us have kind of totally converted our practice in a minimally invasive surgery option. So MIS TLIF, steps of MIS TLIF. So positioning of the patient, docking and wanding of the tubular retractors, facetectomies, depression, decompression, annulotomy, discectomy, end plate preparation, interbody fusion with cage and graft. So what should be seen in pre-op? You should have a standing AP and lateral X-ray. You should have dynamic X-rays. If you are working a multi-level, you should have a scanogram, complete spine X-ray. MRI lumbar spine to assess the compressions from where all is the compression, how much is compression is there on both the sides. A CT scan if you're especially planning a revision surgery, deformity or a complex anatomy is there. DEXA, as was discussed, or our Hounsfield unit in CT, you can assess the osteoporosis of spine, which can be really challenging, and you need to put in screws. If suppose the patient is severely osteoporotic, you should be ready with fenestrated screws. So as in, if you need a cemented screw, you can use that. So operative site determination is usually done on the more painful aspect. So the patient is going to tell you that I am having more pain on the left side, on the right side. So we usually approach the patient from the side from where the patient is having more pain. And as was being discussed, pedicle cage assessment of the lordosis assessment, PILL mismatch, these all needs to be done. PAC and medical fitness needs to be done. Then we take the patient to the theater. This is the positioning of the patient. The most important aspect, the area should be free for the C-arm. You should be able to get orthogonal views. True inverted position should be done. On one side table so that you can move the C-arm. The abdomen should be free. The hip should be extended. There should not be any flexion, because we are fusing spine. The moment you're flexing the spine, you are going to reduce the lordosis. You're creating kyphosis at the lumbar spine. So that is a very, very important aspect. And even during the surgery, we are also going to discuss in spondylolisthesis that we move the table, but we move the table en bloc. You don't break the table from between. If you break the table from between, there are chances that you are creating kyphosis at the back, and the patient will going to come back. The leg pain has gone, doctor, but my back pain is not going. So that is the situation. You should be very wary about those situations. The hip should be extended for the lordosis restoration. This is the OT setup. The surgeon and scrub tech is on the one side. The microscope, usually I put it on the opposite side. This is a slide from AO. They use it from the same side of the surgeon. It basically depends on the length of the handle that you're using. So a Tivato or a microscope which is having a very long handle, you can use it on the same side. But it is preferable if the handle is maybe a shorter, then you can use the microscope on the opposite side along with the C-arm. The assistant stands on the opposite side. The screen is on the side so that the surgeon can see it very clearly what is happening. The instrumentation, the Kerrison rongers, pituitary rongers, the tubes, the disc preparations, things. Since most of us have been doing at least open TLIFs, and we are here to pivot from open to MIS, so most of us knows these instruments, and this is what we use. So cages, screws, and rods and biologics are the implants that we use. Now let's go to the surface marking. How we mark the surface. So this is the tilting of the C-arm. We tilt the C-arm to get orthogonal maneuver. So when you get what is orthogonal view, the end plate should be parallel. Okay, you can see the good pedicles here, and you mark the pedicle with this guide wire. This is how you mark it. So this is a case where we are doing a 2-level TLIF. So we first mark the horizontal pedicles L4, L5, S1, all are marked like this. Then you mark the lateral aspect of the pedicle like this, so as to for your screw entry sites and for your docking of the retractors. This is how a complete thing is marked. Then you give a local anesthesia along your line of skin incision where you are giving, and then you cut it, and you do a docking of the tubular placement, or you use the dilators and do a dilatation of the muscles, and you dock your retractor. So it is very important not to go too medial and not to go too lateral. If you are too lateral, then you will need to bend the tubes. You need to bend the table a lot. So it is best is to be on the center, so that you are at the center of the facet joint and you can do the procedure. So what is banding? This is banding. We kind of use this to kind of remove the muscles and go in as deep as possible. Your retractor should be dead deep. It should be just above the facet. If there is a lot of play between the facet, the tube and the facet joint, so a lot of muscles will keep on coming in and creeping in and disturbing you. So this is like a final docking at the center, and in the lateral view, it should be collinear. So you are going to go in the disc, so it has to be collinear. It is very, very important, especially in spondylolisthesis with high sacral slopes. It is very difficult to get that collinear, alignment in spondylolisthesis, and we are going to discuss that even in tough cases. So how to start with the procedure? Facetectomy is the first step. Facetectomy, we will remove the muscles above that. And I use osteotomes personally. So how we do it is being demonstrated here. This is the inferior articular processes 1 and 2. We are using osteotome in 2 directions, step 1 and step 2. Then the inferior facet comes out. And then after marking the superior articular process, so that you don't enter the pedicle, we remove the superior articular process. This is the videos showing the same. So this is the picture. You can see the muscle. First of all, you will be removing the muscles. The tubes is already docked. So we are trying to identify the facet.
So which is the leg end and which is the head end, sir?
So this
Cranial
is,
caudal.
you can see my pointer. Are you able to see my pointer?
Yes, sir. Yes,
This is
sir.
the
Yes, sir.
cranial, this is the caudal end, this is
Okay.
the medial, this is the lateral. So this
All
is
right.
the IAP, inferior articular process. This is the SAP. This is the medial facet or lateral facet. That you can say like that also. So we are just removing the muscles which are over there, overlying there, and you can see this now. This is the facet joint. Okay. So I'll be kind of using videos only to demonstrate this, most of the surgical steps. So we are discussing facetectomy. You can see this is the facet joint. And this is the osteotome. It is an oblique one. It is not coming in my, microscopic view. This is how we remove the medial facet or the IAP. So this has been removed. Now we will mark the lateral facet or the superior articular facet. So how I do it, I will mark it with cautery along the disc. It has to be along the disc level. I will mark it in my C-arm. So this is like a more or less a Cambin's zone, and it is very safe. And I will just use the osteotome and remove this, which we'll be doing in just another few seconds. So what I am doing here is kind of removing more of inferior articular process, because once I am kind of osteotomize the superior articular process, it should be free from all sides, so that I can just use my step and remove it. So that is what I'm trying to do here. So we try to take the superior lamina. We cut at the superior lamina, and if you see this is the area the dura has started to come. So we cut the superior lamina till the point the ligamentum flavum is free, completely free, and we can just use a Ryler or a pedicle probe to kind of remove it and take it out. So I'm just trying to remove the adhesions from the bones. So more or less the ligamentum flavum is free now. The bone work is done. You can see more or less the superior lamina, the ligamentum flavum attachment from the superior lamina is done. It is free. This is the area. This is free. So now we'll just uh, use a hook to remove this, and the nerves and the dura will start coming in. You can actually see it. So this is the hook that we are using. So good thing about MIS TLIF is we use very big instruments here. Like it's a 5 mm Kerrison Ronger that I'm using. So we are very fast. It's a very fast. This is the traversing disc. So this is the same case. This is a very difficult one. So this is the traversing. Now this is the nerve root, and so the spondylolisthesis is a special form of situation in MIS TLIF where the nerves are at different level. So the traversing nerve root is higher, the exiting nerve root is lower. Because of that, there is a bone ledge. Even after you remove the facet joint, there is a bone ledge which is covering the entire exiting nerve root. It will be always there. So if there is somebody who's starting with it, they can actually miss it. They if you are not seeing the exiting nerve root, you are missing something in spondylolisthesis, because it is the exiting nerve root that is actually compressed. So you can see here, we are trying to find out, this is the fibrotic area, the pars where pars is broken here, and it is grade 3 listhesis, everything is fibrotic. So it is usually difficult to, decompress the exiting nerve root. So we are trying to find, the area, channel through which we can just go in and remove the bone over the exiting nerve root. So this is the entire, yeah. So this is entire, this is bone, and this is the nerve root. So this is the disc. So we are cutting using the burr. We are still, trying to find out the area from where we can remove this ledge of bone, and the nerve root can be freed. So you can see everything. It is so tight. It is so tight. This is a 1 mm Kerrison ronger, and it's so tight. It's still not going. Now we have reached this place. We are able to kind of go in and remove the bone which is there over the, and you can see the nerve root. So the nerve root has started to come. This is the exiting nerve. You see, it was so tight. So it was always there like this. So now the exiting nerve root is totally free. So you can see a very well and a big exiting nerve root going there, which has been freed. Okay, so once you have kind of freed the nerves, it is just like a normal open TLIF. You do a discectomy, you remove the disc, you prepare your end plates, you use your curates, your end plate is prepared well, you put in a bone graft, and you kind of put in a cage. But we usually do over the top decompression. This is a diagram showing the over the top or contralateral decompression. So if the patient is having bilateral pains, so one should do over the top decompression and kind of free the opposite nerve root. So this is just to show how an over the top or a contralateral nerve root decompression is done. This is the opposite side. This is the head end. This is the caudal end, and we are on the opposite side. So how we go to the opposite side? We just tilt the tubes and the microscope. We tilt the table. The patient should be tied to the table, because you are tilting the table on the opposite side. So patient should be well tied while you are positioning the patient, so that the patient don't slip in. So you can see the opposite ligamentum flavum, after the bone has been cut, you can see the ligamentum flavum, which is compressing the opposite nerve root. So this is the traversing nerve root on the opposite side. You can see this white structure. This is the nerve. Yes, it's free now. You can check it with your instruments that it is totally free. So you can also do a discectomy on the opposite side. This is a case of infective spondylodiscitis. Again, showing over the top decompression. In this, we have done a discectomy on the opposite side. So you can use shavers from ipsilateral side. You can go over the top and use shavers, and prepare the disc on the opposite side as well. So we have tilted the tube, and we're going further, on the opposite side. Just 2 more minutes, Chiranjeev. It's more or less done. Okay.
So no worries, sir. It's all you. So in fact, we are getting good viewers. We have already crossed 600 viewers, and they
You
are
see
most
the
interested.
opposite ligamenta flavum compressing the disc and the nerve. This is always like this. So you need to take this out. If you don't do this, the opposite side will not be decompressed and the patient will not be free from opposite side symptoms. So now you can see the disc. Now the disc will start coming. This white structure is the disc, and we can move the dura, and the disc is visible. The entire disc is there, right in front of you, and you can do a discectomy. So even in disc cases, the extraforaminal disc, if you want to approach an extraforaminal disc through a tube, then this is the way. You have to go on the opposite side. I think it's done. Thank you. Thank you.
Thank you very much. I think so. This was an amazing session. Good video, sir. It was fast paced, but we were able to understand the gist of it. That was a great thing. And giving us overall the idea of doing the decompression and how to do over the counter decompressions on the same side as well. And plus the flow, which is very, very important, which has been there. Okay. Thank you, sir. I think so. There are a couple of questions which has been dotted down. I have. So by the end of this session, we will have those questions to you, floated to you. But I think so. The next topic is the one which is most awaited topic, and it will be by none other than Dr. Amit Jhala sir, and he will be showing his experience overall, and his cases over the entire course of his professionalism. Uh, Dr. Amit sir, you're there?
I'm there. So,
Yes, sir.
what I'm going to talk about is because you know that everyone has talked about the fusion. So, I'm going to talk
Yes, sir.
about when
Sir,
to
we
do the
can't
fusion.
see you, sir. Sorry. Sorry, sir, we can't see you. Yes.
Okay. Yeah,
Yes,
yeah.
yes, sir.
So, let me talk about. Oh, you unshared the screen?
Yes, sir. Your screen has been shared. You can just go down to your presentation, which is below, uh, and open up. Yes, and you can just full screen it in below where the zoom in is there, sir. Yes, sir.
That's it. Okay.
Thank you, sir. Over to you, sir.
Okay. So what I'm going to discuss is not the cases, but this is one of the very important topic, and there is a lot of debate. And for the young surgeons, they want to know when to decompress and when to fuse. So I'm just going to take this small lecture on lumbar canal stenosis, when to decompress and when to fuse.
Great,
The
sir.
cases I think we are having in the next part, and I've seen a few cases which and they are very nice cases. So we'll have that discussion after. Okay. So lumbar canal stenosis, you know that age doesn't spare anyone. And we know that everyone changes from exterior and you are going to age no matter whenever whatever age you are going to age. Okay, and what we see from outside is the changes in the skin, but the same changes are occurring in the spine also. So if you see, this is the spine of a very young patient, and you can see this is the spine of an old patient, and that is all an aging phenomenon. And this is what we are talking about is the lumbar canal stenosis, and we are having a lot of changes which are occurring at each and every segments of the spine. So this is what is going to cause in all degenerated cases the lumbar canal stenosis. So this is known as a spinal canal narrowing. Now there is a difference between a lumbar canal stenosis and a spinal canal narrowing. And Postachini gave a very nice definition that if narrowing is not severe enough to cause compression of the neural structures, the spinal canal is said to be narrow but not stenotic. And this is very, very important. Whenever we say that there is a lumbar canal stenosis, there has to be a clinical symptom on clinical grounds that the patient should have the claudication symptoms. So stenosis is not is on a clinical grounds, not on the mean sagittal diameter on MRI or a CT scan. So that's the basic difference between a lumbar canal narrowing and lumbar canal stenosis. So what we are going to talk about this stenosis and why it is important as on today. If we see the World Report of Aging and Health of WHO, so lumbar spinal stenosis is one of the most common spinal degenerative disease which affects the quality of life, and about 33.5% spinal surgeries today are performed for lumbar spinal stenosis. So you can see the amount of load on the spine surgeons, that around 33%, every third patient we operate are of the degenerative spines. Now we see the natural history of lumbar canal stenosis. Majority of the patients don't improve. 15% will have worsened, but 70% will have unchanged. So there is no acute deterioration. And surgery is there only to improve the quality of life. And this is very, very important. And this is what we counsel during our in OPD also. So majority can live without with stenosis if they accept the disability. And this surgery is only and only for improvement of the quality of life. So this is a very, very important statement that everyone should remember. Now, when there is lumbar canal stenosis, what is better? Surgery or a conservative? And there are n number of papers which have proved that surgery is better than conservative. But there is a caveat. Even if you do a surgery, there is a long-term deterioration results of surgery at 10 years. But still the patient is much better for about 10 years. So this is very, very important that you advise the surgery, patient will have improvement of quality of life for at least 10 years for lumbar canal stenosis. And that's why surgery is always recommended if the patient is willing to improve the quality of life and doesn't want a disability in their cases. So this is very important. Now, when we come to the surgery, lumbar canal stenosis has got two parts. One is a simple stenosis and other is a complex stenosis. Now, what do we mean by complex stenosis? If the patient has got degenerative lumbar spondylolisthesis, scoliosis, adjacent segment disease, or an iatrogenic, where previously there was op surgery, or during the surgery you remove the facet and then it becomes a complex one. So simple stenosis usually requires a decompression, and complex stenosis usually requires a fusion. Now, this is very easy to say that we will have a decompression in simple stenosis and in complex we will have a fusion. But the big problem here is what is a simple stenosis? And that is where the whole problem lies. That what is a simple stenosis? We don't know what is a simple stenosis. And sometimes we feel that we do a decompression in the case of a simple stenosis, they can get converted into a complex stenosis because of iatrogeny. And that's a big dilemma that we have in our routine practice. So what is simple? And if we do a decompression, considering it as a simple, it may turn out to be a boomerang and the patient may come back to you. So this is a very important part of the discussion. Now, why this is important? There has to be a critical balance. Simple stenosis will require decompression. And as on today, everyone wants to just do a decompression with an MIS coming in the way, in a big way. Why decompression? It is an easy procedure. There are less complications. Risk of instability and reoperations are less. But the cumulative reoperation rates are at 4 and 8 years are around 13% and 18% if if you do only decompression. So there is also a postoperative progressive spondylolisthesis which can occur if you just do a decompression. So that also needs to be factored out. If you do a fusion, it becomes a more complex procedure. There are more complications. There is more risk of adjacent segment disease. And you know that there is an exponential rise of adjacent segment disease as you go in longer. So if you have adjacent segment disease in 7 years is 5.6%. But if you go more than 10 years, it becomes much, much more. And if you do a longer fusions, then the rate of adjacent segment disease is much more. So you have to have a very critical balance when to use a decompression and when to use a fusion. Now, the other dilemma is sometimes the simple stenosis will also require a fusion, and complex can be treated by decompression. And this is also I'm going to touch upon. So this is really complex decision-making issue. And for that, what to look for? If you want to do a fusion, you have to prove that there is an instability. So that's the primary key, that if you prove that there is an instability, then you can go for a fusion. Otherwise, decompression is okay. But instability again has got an evident instability. There has to be a hidden instability, or there is a potential instability which you should pick up. Because if you just don't pick up this hidden or potentially unstable, the decompression is going to fail. And there can be sometimes an evident instability, but it can be a stable, right? So what are the criteria for each of them? So what is a simple and what is a complex? I've already defined. So there is a checklist to find out what is a complex stenosis, and that is preoperative, peroperative. In preoperative, you have an X-ray and an MRI. Now you see, these are 4 pictures of the patient having a lumbar canal stenosis. 1, 2, 3, and 4. So what you should look for in an MRI as a preoperative checklist. Everything looks like a simple stenosis. There is no listhesis anywhere. Okay. But there is a hidden instability in each of them. And what criteria you should look for in each of them. So these are the axial. And axials are very, very important to look for in lumbar canal stenosis. Now, what you can see in axials, what is the difference in all 4 pathologies that you see? First thing that you look at is the facet joints. If you see, the facet joint angulations are quite different in all the 4. And this makes a very, very important observation, that if you have a sagittal facets, even if you do just decompression, this patient is going to come back with a potential instability later on. So this facet joint angulation is one thing that you should look for. The second important part that you should look for is the facet synovitis. So if there is a facet synovitis or facet fullness, that is a potentially unstable spine. So that is also second criteria they should look for. The third very important criteria is the interfacetal distance. If you see this interfacetal distance and if you see this interfacetal distance, so this is quite less. And if you try to decompress here, this is a congenital stenosis. And if you just try to decompress here, you may not be able to completely decompress. And if you want to completely decompress, this facet needs to go out. So this will become a potentially unstable peroperatively, because you will not be able to preserve this facet joint if you want a complete instability. So these are the things that you should look for. The other important part is the canal. You see, the shape of the canal is quite different. This is again a trefoil canal. So if this is a canal, the decompression becomes easier. But if this is the canal, this facet has to go, and this will become potentially unstable. So these are the 4 things that you should look for in axial MRI to find out preoperatively whether you will require a fusion or not. What should be the facet angulation? Facet orientation has to be greater than 58, then it is unstable. If fluid in the facet joint is greater than 1.5 millimeter, then it is unstable. If a trefoil canal, you have to be very careful just doing a decompression. And if you have a small interfacetal distance, you should be very careful that you are not going much lateral so they don't damage the facet joint. So usually if you see, this is a facetal cyst and this is a facetal synovitis. Now this comes into the criteria of instability, but just a facet cyst is not the criteria of instability, and you can just decompress this facet cyst alone. So if you see these 2, then this is unstable and this can be managed just by decompression alone. Now on X-ray, what are the criteria for instability on X-ray? Sometimes the patient comes with only MRI and MRI is not enough. You require an instability view. If there is a degenerative listhesis greater than inflection, then this becomes an unstable segment. So this is a hypermobility. You see, can see that these 2 are, there is no listhesis. There is a in extension and flexion, you can see that the angulation is more. But this is a hypermobility. This is not an unstable. But here you can see that there is a 2 millimeter of offset as well as a kyphotic deformity, which is happening in flexion. So this becomes an unstable segment. Okay, so this is very, very important. The other things you can pick up on X-ray is, these are known as traction spurs. If you see this X-ray, this is a sign of instability. You will have unstable and shear forces on the disc, and you will get these osteophytes which are formed. And these are known as traction spurs, which is a sign of instability. And dynamic views, of course, I've talked about the dynamic views at all. Now, MIS over the top decompression. Has MIS decompression made the difference in any of these criteria? The hypothesis is that we do a less destabilization because we preserve all the posterior ligaments and posterior structures. So has MIS made a difference? Yes, it has definitely made a difference in today's world. And if you see that just an MIS decompression in the listhesis definitely works, but there are certain criteria to follow. And therefore, I say that you can do a complex stenosis with decompression alone. So that becomes a confused picture now. So now what are the criteria for just doing a decompression? So when you can do a decompression in a complex stenosis with listhesis. So if the patient has got a predominantly leg pain, patient is old age, patient has got a stabilizing osteophytes, decreased disc space, there is a stable listhesis, low BMI and low demand, then you can definitely just do a decompression in a complex stenosis. And this is what I can say, that if you see this patient has got a listhesis inflection, but there are a lot of osteophytes, the disc height is very less, you can just do a decompression. There is no disc height at all, and you can just do a decompression in this case. So these are very, very important things that in complex also you can do a decompression, and you have to follow certain criteria. So when not, this is what I already talked about, that facet synovitis, joint angulation greater than 58, greater than 50% of the disc height, and in scoliosis, if you have a disc wedging, supposing you want to do a disc decompression in a scoliotic spine, there's a disc wedging of greater than 3 degrees, then it becomes difficult to just do a decompression. So that is where you have to actually fuse, because stenosis is very difficult to treat. So scoliosis and 50 only decompression is contraindicated. Okay, so that comes into decompression variation. There's isolated nerve root involvement. It's a stable spine and less than 15 degrees of curve. Then you can definitely just do a decompression even in a complex stenosis of a scoliosis. And this is a criteria given by Fernando and by De Silva and Lanky. And this is, I will ask everyone to go through this article. So what are the peroperative situations? So these are the preoperative checklists. And what are now peroperative situations? If you want, if this is the case you are doing, if you remove the facet joints with more than 50% and if just peroperatively you feel that you have removed the facet, then you have to definitely do decompression. If you do a bilateral discectomy from in the same patient, then disc becomes very unstable, and these patients need bilateral fusion peroperatively. If you do a multi-level laminectomy in a deformed spine, definitely you require a decompression. And if you are doing a revision spine, and then you sometimes remove the facet joints, and then you consider the fusion. So these are the peroperative checklist in the peroperative situations where you require definitely a fusion. Some clinical examples to show why it matters. So this was a simple stenosis. All right, everyone feels that this is a simple stenosis. There was severe stenosis at L4-5 with facet orientation about 45 degrees. 12 years follow-up, patient has occasional back pain, complete laminectomy done, and patient has no problem. But you see here, the case 2, again a simple stenosis as like before. Okay, it looks a very simple stenosis. Just do a decompression. But you see the facet joint angulation. The facet joint angulation was 70 degree in this case, and laminectomy done before 13 years, and patient presented to us with a gross deformity. Of course, this was a deformity the patient was lingering on, and that's why the patient got a gross deformity 13 years post-op with severe claudication, and then it becomes a very complex case for the surgery. And this is what we had to operate. These are the standing and films, and that's a severe stenosis which is there, and we had to operate. But you can see that we have operated only at the place where the previous laminectomy was done. We have not done a full curve correction because the epicenter of the deformity was only and only at that level where there was a deformity. So always check for facet joint orientation. So that was a pre-op, and that is the correction with the post-op correction. So it's very important that, in summary, simple stenosis, what is? There is a low back pain. There is no clinical deformity. On X-rays, if on instability views, there is no listhesis, coronal angulation greater than 15 degrees, no spinal rotation, no coronal translation. MRI, if you see, there is no facet synovitis and facet joint angulation is less than 55 degree. Then you can consider it as a simple stenosis and you can just do a decompression. But if you have a clinically a spinal deformity, there is a malaligned unstable spine, listhesis, scoliosis, kyphosis, oral lordosis, loss, then you have to consider it as a complex stenosis and go for a decompression. In MRI, you look for sagittally oriented facets, facet synovitis, listhesis, asymmetric facet degenerations, rotations of the vertebra, and multi-level degeneration. So these are the criteria that you should look for whether to go for a decompression or a fusion. Thank you very much. It's a short presentation, but this is what I wanted to talk about.
So it was a short, but I think so it was more indulging actually, to be really frank. Wasn't it, Dr. Ashish sir and Dr. Sharvin sir? Like, the concept of trefoil canal, facet angulation, there's something, I've seen it like, I have not seen it much, but this is something I got very interested. Sir, Ashish sir, what is your opinion about it, sir?
No, a wonderful presentation. Boss is always, a great presenter and he has great knowledge about everything. So thank you, Dr. Amit, for sharing such great insights on the topic.
Thank you very much, Ashish.
So,
Yeah,
Ashish
really
sir, do you...
great,
Yes, sir.
great presentation with very illustrative, and it has given a clear idea of which patient to be selected, and very fantastic presentation.
Thank you, sir. Thank you very much.
Dr. Ashish sir, I wanted to ask you one thing. Sir has a criteria of doing the surgeries and in doing the fixation or decompression. You also have certain criterias that you follow?
Sir, as sir has told, the sagittal angle is very, very important. I also, ask the patient about the back pain. If the patient is having very severe, I ask him to rate his back pain with on the VAS. So if the patient is saying, see, I have very severe back pain along with the radiculopathy, so that is also one thing that goes more in favor of fusion for me, because I believe that just by doing decompression, back pains usually don't tend to do that better, and that is also one thing that I wanted to add maybe in this.
Okay, okay. Dr. Shravan sir, sir did also mention a point about the degeneration. And he also showed some pictures that the age will catch up to you overall. But does the degeneration basically goes as per the age, or it is something else or something different overall?
No, I think age is going to catch up after all, like, after all of us. But what happens is sometimes some activities that we do or the patients do might aggravate or accelerate the process of degeneration, and that can lead to the problem of chronic back pain and the chronicity of back pain, which may require fusion. Another point which also Sir said and even Tomar Sir has mentioned is we need to properly align when we are fusing, because if it is not properly aligned, then a previously normal segment can also go for degeneration even in a younger patient. It does not have to be because of age catching up to you. So
Correct.
it is a multifactorial thing, and we need to look into all the points before selecting a particular procedure for a patient.
Okay. So I think the post COVID area, we have been seeing many young patients coming up to our clinics, and we have been seeing those are basically the degenerated cases as well. If am I right? Am I wrong? I'm not aware of it. If you can just highlight on those particular point, because I think so. One of the thing which has been going on out in India is also like the awareness of the spine, which is very important, and many people who are working from home are basically not being so sensitive about it. If Shravan sir, Amit sir, Ashish sir, Sona sir, if you can just share your viewpoint on it.
So I think exercise is very, very important. I am sure all of us are 90% of the patient is having some sort of back pains and things like that, which usually get better with exercise. Muscles are very, very important. So work from home and things like that kind of deteriorate your mobility, and that leads to development of more of back pain and things like that. But so people need to be counseled about exercises. And apart from what I was talking about the back pain aspect, there is another very important thing. I believe that inflammatory arthritis is also very, very common. It is kind of missed also a lot, and a degenerative process kind of progresses in these patients who are having inflammatory arthritis, whose back is kind of being inflamed and the facet is going bad. And so if they are maybe diagnosed early, so those degenerative scoliosis and those degenerative problems may be seen less, maybe prevented in some of these maybe.
Okay.
Usually,
Sona
that's
sir,
the
you,
key point.
yes sir.
I agree with Dr. Amit Jha. That first question, when they come with this problem, I ask whether which one is troubling you, whether it's back pain or leg pain. It's a clinical diagnosis to decide what we want to address, how do we want to investigate further in point of view of surgery, whether it is decompression or fusion or which level we have to go ahead.
All right, sir. All right, sir. So before we go into the question, and because I have a lot of questions in my mind, and I've also got a couple of questions from the comments as well. We will go to the next session, I think. So that is the lessons from my toughest MIS cases, and in which Dr. Swarnakumaar and Dr. Ashish sir would be giving up the presentation. Ashish sir, would you like to take this opportunity and go with the first, and then we can cover with Dr. Swarnakumaar, or it can be vice versa as well, sir.
Yes, I am okay with this. I can start sharing my cases. I mean, there I've so it's been like it's a small few cases only, few situations only, which I'm planning to discuss, because it's just 5 minutes, I think, that is there. So is my screen visible to
Yes,
everybody?
sir. Your screen
Yes.
is visible, sir.
So one thing that I really want to talk about, the difficult cases, is the high grade listhesis, grade 3, maybe going to grade 4. These kinds of situation. So, like the case we have already shown, this is one of the cases. This is another case of high grade listhesis. These are now can be routinely managed with MIS TLIF, but the specific problem is that these patients sometimes have very high sacral slope. You can see the pubic rami is going, the angle of the disc is quite in sync, going inside the pelvis. And to get as I've was discussing in the surgical steps, you need to be totally collinear with the disc, so that you can go in you can put in a proper cage placement can be there. You don't break the end plates, and you are going exactly in the disc. You have to be very collinear. So this is what happens when you try to be collinear. The tubes needs to be tilted a lot. Your microscope needs to be tilted. The microscope tilts to one to some degree. Beyond that, so what we do is we kind of move the patients, en bloc. We move the patients in this position with the head end up and the tail end going down. But there is problem with this also. The moment you do this and you kind of overdo it, what happens, your instruments are difficult. Your instruments are going, when you are taking a bite with the kerosene, it is again and again getting stuck with the back, and the back is coming because the patient head end has gone up. So the body starts coming in between if you overdo it. So this is one difficult situation. So you need to kind of tilt the tube, you need to be collinear. And sometimes, as a tip, what I do is, like, I will do the decompression and I will put in a shaver and kind of tilt the tube and work outside the microscope. Sometimes the angle is so steep that you need to work outside the microscope, and you use the C-arm. You can just use the retractor. You just hold the nerves, uh, further increase the angle of the tube, and then use the shaver and work in the disc. So that is something that has helped. But whatever you do, these are difficult cases, and sometimes it becomes really difficult. So this is another tip that I wanted to share. So these are, like, you can see, these are cases in which the disc is really gone. So once you kind of so it is difficult to put in a cage without breaking the end plate. So if this is also a good way to put in a proper cage, is that you can put in a screw on the opposite side, and you can lock that screw. so that the disc height, what you have achieved, is maintained. Then you can put in a cage. So that is one way of, achieving the height and putting in the spacer and the cage without, causing end plate damages in these cases. So this is just to show we have, used the put in a screws on the opposite side, and this disc height is maintained, and then we can easily put in the cage. This another situation that is difficult is an infected spondylodiscitis, or while doing the surgery, you actually break the end plate. So what has happened? The end plate is broken now. So these are different scenarios where we are doing infected spondylodiscitis and putting in a cage. This is just to show in some situations you'll be putting very big cages to hold this. And this was a case where just a 8 cage could go in between the bone. There was bone. It looked as if the bone was totally destroyed, but still a small cage also could hold in. And it depends how the end plate is there inside, and what the situation is like. If you see the x-ray before putting in a cage, you will feel that you might need a very big cage for this situation. But actually we were able to use just an 8 cage, and it was snugly fitting. So it is the hold of the cage. And this is just to show this video how what happens. I mean, you if suppose the end plate is fractured, or it is an infective discitis like situation, so you can check. This is just showing. You can see the cage is moving. If this cage is moving, you cannot just leave that cage. So you either go in and put in a bigger cage. Like in this situation, this was the 12 cage. We have to put in a 16 cage to get that snugly fitting good cage and good. This was the X-ray. This is the patient. You can see this big cage has been put, and then there was we were able to kind of get a decent fixation anteriorly. But in certain situations where you break the end plate, the situation will be same. Then sometimes you need to go on the opposite side. You need to go on the opposite side, do decompression, do fascicectomy, and put in a cage from the opposite side. This was the patient where we accidentally injured the end plate. This was a straightforward listhesis case, but we injured the end plate. So if you see this case, this is on the opposite side, right at the edge. It is because we have broken off from the left side. So I had to go on the right side, do a fascicectomy again, and I had to put in this cage from the right side. Then the day was saved. Otherwise, it would have been a very difficult situation. If you put in a loose cage, that cage will come back and it will cause problems. Another, very devastating complication, not in MIS, just wanted to share. This can also happen, and it happened to me twice. Because in open surgeries, I used to put, I am a person who is a frank, who likes putting in cages from both the sides, bullet cages. So sometimes this can happen. If you are not careful, if you are not seeing the C-arm and you just hammer the cages, the opposite side cage can go anteriorly, and it can be a big problem. This is dangerous. This is very risky, but this has happened to me twice actually. So now I'm very careful about these things. I always, when I'm putting my second cage, I always use C-arms. And I'm just wanted to share how I, in this situation, how I got out. You can see this is these two cages are of the same size. This went anterior, but I was able to see from the microscope this cage. So I have put in a bigger size cage on the opposite side, so that this cage becomes loose. And gradually, with luck, I was able to get this cage out. This is the picture show that the cage has come back, and I was able to pluck it out. So in another case, I was not that lucky. So as I was telling, there are two cases. I had to go in anterior. So these are difficult situations which I have kind of seen faced in my career, and I just wanted to talk and discuss about them. Thank you.
Thank you, sir. That was a really interesting case, actually, overall. Would like to ask you a couple of questions, but Dr. Sona sir, would like to share the presentation if you have any for
Yes,
the
yes,
yes.
I will do that.
Your
Yeah,
your toughest lesson, sir. Yes, sir.
1 minute.
We can see your screen, sir.
Yes, okay. This is you can hear me? Yeah.
Yes, sir.
Okay. So this case, just I want to show this patient was 56-year-old female obese patient, and it was done elsewhere with L5S1 MIS fixation only. And the patient could not sit for a long time, and he had difficulty in walking, and she was able to only walk on a short distance with support. Her back pain was more than leg pain, and she had bilateral lower limb weakness, mainly L5 and S1. So this is the X-ray. She came with very osteoporotic bone. She had many comorbidities. She was on steroid for a long time because of the pain control. You can see, according to the first lecture, we saw so many mechanics about these implants and fixation techniques. Here, the MIS fixation, one few things we can see. The screw size is small, and she had instability with another level disease. So she has to undergo a long fusion with decompression. So with comorbidities, if it is not fused anteriorly, she'll be in trouble to go again. So this APV also we can see in this level. So problems we faced is a broken screws S1 because of it's a 5.5 screw they have put it, and instability at L5S1, and additional instability in L1, L2, anterolisthesis in L2, L3, and retrolisthesis in L4, L5. So my plan was to go for MIS, but the challenge was to remove the implant already there. That was my option one, to go for the MIS screw fixation L1, L2, and MIS T-lift to L1, L2, and L5S1. I explained to the patient, although she is having many comorbidities, I might have to go for open surgery. So I explained the option of open surgery, removal of implants. And anyway, I had to go for the open surgery for the removal of implants. And it was a challenging, and I had to convert to open surgery. So this was the surgery. Ultimately, I had to go for the open procedure, although I planned for a missed surgery. Initially, one missed surgery was failed, so I didn't want to have another surgery for this patient. I can't afford later. So I explained to the patient while on table. I spoke to the husband and explained this fusion. We can see L1, L2. I had to put L1 screw, augmented screw, because she was osteoporotic. This is the very long lever arm. It can easily pull out at L1. So L1, L2, I hit a cage, and L4, L5S1 also I had to put a cage. And previously screw was fixed in S1. So it was loose when I put the second time screwing. So I had to put for the sacral screw as well. So this is the case. She was, okay, these are the implants I had to remove. And the reason for failure, I am repeating, small diameter of screw. As I told you here, we had to go for even 7-8 millimeter screws can be accommodated depending on the sacral size. And always we have to consider 300 degrees fusion, and the patient was obese. So I put with larger screws to S1 and L5, and I achieved 300 degree fusion, and cement augmentation to L1 to achieve better screw purchase. That was my case. She went on well with good outcome.
Great, sir. Great, sir. Amit, sir, what different you could have done, like matlab, if such
Really,
case
this
comes?
was a very challenging case, and I would have directly gone for open. And because of severe osteoporosis, you require a long fixation. You have to remove the broken screws. So
Yes,
it's a
yes,
fantastic result, I'll tell you. But I would have gone directly as an open. I would not have attempted
yes, yes. Even
MIS.
actually, they came with an idea. It was very difficult to convince them, but I had to, yes, I did it open. Okay.
But so just one question: if it was an L1, since it is a junctional, we could have gone one level above as well.
I think this is going to be a big topic for the next webinar.
Yes, okay. We will do think of that UIV. Yes, UIV decision. Yes, that'll
It's a
be a
big
good topic.
webinar by itself.
Yes.
Correct, correct. So maybe we got a topic for the next webinar series and we can have a lot of discussion on that as well. All right. Now, I think so. This is an open forum where we can have a couple of questions. I will just lay down a couple of questions that I have received from the site. Okay. So this is specifically to Dr. Ashish sir. So you show us the failure cases, and on that particular basis, one question arrived. I think so. During the disc preparation, while putting the cage, what is an ideal preparation should be done to how much disc material will be removed?
So it is like the area where you are kind of planning to put in a cage, that area
Correct.
needs to be completely removed. I mean, the if you are like you are working on the left side, you have
Hmm.
written in the root, the entire area needs to be completely removed. That disc needs to be taken out. It is not
Okay.
about removing the disc that is more important. It is about preparing your end plates. So end
Okay.
plates needs to be prepared. The cartilage needs to go out. The curates needs to you need to curate. You need to take some time. I'm a person who is a big fan of putting in bone grafts. I believe that putting bone grafts do help. It helps with the fusion. So, in fact, we have instruments, if the size of the cage is more than 10 mm, we kind of use funnels to put in the bone inside the disc space. So that is the thing basically. So it is like the entire disc needs to be taken out from that side where you are putting the cage, and then you can put the cage.
Okay. Okay. So, Amit sir, any point of view, sir,
Yeah,
from
so
you?
whatever you do, maximum you can, with single side approach, you can never remove more than 60% of the disc.
Mm-hmm.
Going to the opposite side and posterior is impossible, right? So maximum you can remove is 60 to 65%. But as Dr. Ashish told, it's very, very important to prepare the end plates. So
Correct.
whatever you are seeing, you should see a very good bony end plates, but don't destroy the end plates.
Okay. Okay. Dr. Sharvin sir. So we also saw some cases where Ashish sir also mentioned that in open cases, he would love to put a two cages on the both the sides and the bullet cages. How about an MIS? Do you prefer to go bilateral or a unilateral approach? Decompressions.
I usually do a unilateral approach because bilateral approach through the MIS would require extensive work on the other side as well. Removing both the facets, again protecting the nerve root, manipulating the root and the thecal sac, and then the same disc preparation. And what I also feel is that the sizing of the cage sometimes is a problem if we try to put both sides. So, if one side, if 10 is snugly fit, on the other side, it might not be. And then if you oversize the cage on the other side, this side cage might become loose and there is always a chance of banging out. So, usually it's always a single-sided approach for me and a single cage. Over-the-top decompression might be added on depending on the severity of the symptoms and the severity of stenosis.
Okay, okay, sir. Okay, sir. One more topic I think so, with the people are trying to understand is adjacent segment disease. Now, this is something which we have talked over this entire webinar series now. And what are those factors basically, or which lead to these adjacent segment disease? Because whatever you do, something else is going to happen to the adjacent segment disease, and how to prevent these things.
So I think as Jhala sir said that adjacent segment disease and the LIV is a talk in itself. Adjacent segment disease is again a multifactorial thing, and no matter what we do, no matter how many angles we get in, and we match all of those, it still happens. So it is very difficult to pinpoint a single reason how to prevent adjacent segment disease. There are, we can all we can do is try,
Hmm.
but there is no definitive answer on how to prevent an ASD. What we can do is we do the best with what we can with our hands, and that is just alignment goals.
Okay.
And of
Okay.
course,
So
the activity level of the patient, obesity, medical comorbidities, a lot of factors are involved in the segmental degeneration. And of course, add age to that. You don't know if it is because of your fusion or it is just the aging process that has led to the segment degeneration.
all right, sir. All right, sir. Sona, sir, any
Yes,
any
adjacent
viewpoint from
segment
you?
disease, we have to focus on the lecture of Dr. Jhala. Yes, he has mentioned about all the instability, and if we forget about that instability when we select the UIB, and if we forget about that and only going for decompression and come out, then it is iatrogenic. We cause this upper segmental adjacent diseases. So it has to be pre-operative planning. It gives a better result for the patient. That's my view.
All right, sir. All right, sir. So we'll come on to the last segment. I think so that will be a rapid fire questions. I have prepared some questions from my end, and we will be starting from Dr. Ashish sir, then followed by Amit sir, then Swarnakumaar and Dr. Sharvin sir. I will be laying down 4 questions each. If you want to explain in brief, that will be great also. But this will be, as I mentioned, it's a rapid. So let's think quick and answer the questions accordingly. Okay. The very first question, Dr. Ashish sir, if you're ready, all's up. Great. So a patient has an osteoporosis with a T-score value of -3. What is your preferred strategy for improving the pedicle screw fixation? Is it a larger diameter screw, longer screw, cement augmented, or bicortical purchase?
Everything.
Nothing.
Everything needs to be done.
Everything.
I
Everything
mean,
has to be done.
like that. You need to have the option of cement. You need to put in longer screws, bigger diameter screws. Everything needs to be done. And bicortical purchase really helps. You know,
Okay. Okay. And how about the dual threaded or single thread? What do you like to prefer?
I'm a fan of dual thread, so I have kind of shifted to dual threads now.
Great.
We don't use more now single thread since the Indian companies are here. I mean, you guys have done a tremendous job, by providing such cheap rates. These technically more, less accessible to patients. Implants is quite accessible now.
Absolutely. So this is one point, you mentioned it, thank you. But I just wanted to understand there was an error where the MNC implant was using at the peak. And as of now, the Indian companies are being introduced into the market and they're improving. They're improving in terms of quality, improving in terms of design. So do you still feel the quality is being compromised, or is it that it's we as an Indian company is as good as with the MNC? So it's a debatable topic, obviously, but let's talk about the patient benefit because many patients do not have insurances. Okay, even post COVID. Yes, yes, sir. Please,
I have kind of more or less moved to Indian companies now. That's so
sir.
good. I mean, and that has been the problem with the MNCs now. So you guys are producing really good implants, and there is the cost difference is a lot, and there is no quality difference. I mean, I don't see any quality difference. More or less, it is fine, and it's really good. All of the Indian companies. It's not just about AOSYS. I think other Indian companies are also very good, and you guys as a industry is doing a very great job.
Amit, sir, your point of view, sir, on this?
I'm a very, very firm believer that we are not doing joint replacement. What we are doing is an implant fixation, and the role of implant is only for first 6 months. So if you have a good biology, then all these implants are only a temporary stabilizers. So if you do a good biological work, if you are doing a fusion, if you prepare well, if you give a good anterior column support, if you follow all these principles, then these implants are going to work. I'm a firm believer. I don't, and of course, what Ashish told is also absolutely right. That now we have got a very, very good industry support, local industry support, and it's not necessary. It was not the implant which made the difference, if I just want to put it. It was the
Yes.
instruments which were a problem if you wanted to do. And that's where everyone was using imported, what we call as into inverted comma MNC implants. But now with reverse engineering, all these things have changed.
Yes.
Okay, so that's my take.
Great, sir. Great, sir. I think the Swarna, sir, you have been using in international only. So there's out there.
Yes,
How's it in Sri Lanka?
yeah.
Yes.
In my career, earlier we were stick to the all Western implants and instruments. Still, we are using. There's no doubt. And now we have moved to, even from the beginning, we have instruments and implants from India and other countries, but not the joints. So, as Dr. Jha said, our main work is only for 6 months. And as far as we properly select the patient, planning and surgeon's factor is important, how we are stabilizing the segments. All are the important. Next come last is the implant material strength or everything. So if you properly select, even my cases, now I certain cases I have decided and seen it was my failure of improper patient selection than the implant. It was a failure. So if you properly select the patient, if you do a proper surgery with a well prepared end plates and stable fixation, usually they last longer. Even now for the scoliosis, I am a scoliosis surgeon. I have used Indian implants, AOSYS implants. Now I have been using
Great, sir.
far better than the previous implants.
All right, sir. All right, sir. Thank you. Thank you for sharing. Dr. Sharvin, sir, if there is an obese patient which is going under MIS fixation, now there are a lot of factors which will actually affect the accuracy of the, putting the pedicle screws. What are those factors basically? Does this factor usually have a what we say causes such concerns, or is it like it's the normal MIS procedures?
No, there are a few concerns. The major concern is visualization of the pedicles in an obese patient, because under fluoroscopy we have to be very accurate, and all the borders of the pedicle need to be visible very accurately. Other thing what happens is, if any of the views, if AP or a lateral view is not clearly visible, then there are multiple shoots at a very high radiation, and that causes a lot of exposure to the surgeon, to the OT personnel, everybody who is present inside the OR. So that is one. Visualization through a fluoroscopy is difficult right now. They have very good quality fluoroscopy CMs also, but even then. Second, what I've seen is most of the obese patients also have a poor bone quality. So add that to the fluoroscopy issue, and the visualization again further decreases. So we have to be really careful. It has to be a haptic feedback, when we can feel the needle touching the bone, going through the bone. It has to be not just dependent on the fluoroscopy, but also what you feel from the fingertips of the hand. And of course, with the help of navigation, it helps overcome all these problems of radiation exposure and multiple C-arm shoots, accuracy. Uh, Navigation just takes away all of those problems.
All
But
right.
agreed, it is in obese patient, one has to be very careful, especially like case which Ashish sir showed in a high grade listhesis, obese individual, poor bone quality, and high lordosis. So that is a nightmare. That case is we have to be very, very careful in all steps.
All right, all right. But Ashish sir, do you oftenly keep open instrumentation during the MI's case, or it's like just the MI set is sufficient enough?
So how we practice, we have open sets available inside. They are already prepared. So if there is requirement, maybe if I'm, it's a very rare thing. I mean, MIS is so comfortable that we can use open instrumentation whenever we need it.
Okay, fair enough, sir. And I would like to thank you, everyone. Amit sir, Ashish sir, Swarnakumaar sir, Shravan sir, thank you for taking out your time. Amit sir, you're there? Yeah, oh,
I'm
we
here.
can't see it. Yes,
Yeah,
yes.
I'm.
So thank you very much. I think so we have come to the closure of this entire webinar series for the 2.0 series, and I think so we have crossed 700 plus yes, and viewers who have been seeing through the Auto TV, Facebook, and YouTube, and it was a great session. Specifically, we got the graph of during the presentations of the case presentations, and thank you again for giving me an opportunity, and thank you for your time as well. So. Any last word would like to say?
No, thank you. Very nicely organized. And I thank actually AOSYS to have this webinar. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir, so much. It's well organized. Good topic to discuss. I think as Dr. Jha said, I think we will focus on the next topic
Yes,
on fusion levels. Yeah.
correct.
Yeah.
Yes, sir.
Okay.
So, thank you, everyone. So, those who are viewing us, we will be coming back again with new series and with new topics. And I think so. We have already discussed one topic, which will be on the complications. And so, stay tuned with us. You can follow us on the AOSYS page, which is on Instagram, Facebook, and LinkedIn, and be updated what we are doing and what we'll be coming up with the many other agendas and training and educational parameters. Thank you once again, everyone, for joining us, and have a good day. Bye.
Thank you.
Thank you.
Bye.
Thank you. Bye.
Bye,
Thank you.
everyone. Bye.